Hello everyone. Today we are going to see about the management of hyperkalemia. Hyperkalemia is a medical emergency and it should be managed very aggressively. Okay, what we should do when we see a patient with hyperkalemia? Before that, we will see one ECG. This is a 50-year-old male with CKD who came to ER with complaints of palpitations. ECG is showing this. Okay, here in ECG, patient is having tall hyperacute T waves. The T waves are tall in most of the precordial leads. So ABG was done at presentation and ABG was showing pH of 7.3 with showing acidosis with bicarbonate of 23 and potassium of 7.8. As patient is a known case of CKD, he is having some metabolic acidosis component along with hyperkalemia. So the tall hyperacute T waves which we are seeing in this ECG is due to hyperkalemia. So how to treat? First of all, before treating, we have to connect these patients to a cardiac monitor. As hyperkalemia is an unstable rhythm, that is, hyperkalemia can trigger unstable tachyarrhythmias or bradyarrhythmias. These patients should be connected to the cardiac monitor whenever there is hyperkalemia. After that, we have to give 10 ml of injection calcium gluconate. That is 10 ml of 10% of injection calcium gluconate over 3 minutes under cardiac monitoring. Why? Why we are giving calcium gluconate in patients who are having hyperkalemia? Normally, what hyperkalemia does is it decreases the gap between action potential and resting membrane potential. So whenever a resting membrane potential is being depolarized, it reaches the threshold potential. When it reaches the threshold potential, action potential is triggered and depolarization happens. So this gap between resting membrane potential and threshold potential is being decreased by hyperkalemia, leading to increased excitability and arrhythmias. But calcium does the opposite. It increases the gap between the resting membrane potential and the threshold potential, thereby decreasing the excitability and thereby stabilizing the membranes. So this is a 30-year-old male who is presenting with acute onset weakness of lower limb. The ECG is showing uh, tall T waves which are sharp, pointed, and narrow based. And there is decrease in P wave amplitude along with prolongation of QRS interval. This is very much characteristic of hyperkalemia. And this is hyperkalemic periodic paralysis. So after calcium gluconate, there is reversal of the changes which you have seen before. There is normalization of the T waves. The T waves are clearly visible and QRS complexes become normalized. So this is the difference. So we have stabilized the membranes. Now what to do? The next step is to decrease the serum potassium levels. What can we do? We can use a mechanism called as redistribution of potassium. As extracellular potassium is high, we can make the potassium travel from the extracellular fluid into the intracellular fluid, that is within the cells, via a mechanism called as redistribution. And two drugs are very important in doing this redistribution. One is insulin and another is salbutamol, which is a beta agonist. Beta agonists are very well known to cause hypokalemia. So the dose of human actrapid, that is human regular insulin, is the brand name of human regular insulin is actrapid. We have to take 10 units of human actrapid and we have to mix it with 100 ml of 25% dextrose and we have to give every 6th hourly. This infusion can be given over 10 minutes. That is enough. And also we can give nebulization with salbutamol. Usually for COPD, for bronchial asthma, for giving salbutamol, the dose is 5 mg. But for correcting potassium, we have to give a higher dose of 20 mg, which should be given in a frequency of Q6 hourly. So by these mechanisms, we can shift the potassium from the extracellular fluid to the intracellular fluid, thereby decreasing the serum potassium aggressively and acutely. Okay, we have decreased the serum potassium acutely, but what about the total body potassium? For removing the total body potassium, we can use potassium binding resins. The most common resin available in the market is calcium polystyrene sulfonate powder at a dose of 15 grams. We have to mix this 15 grams of sachet in 15 ml of lactulose, and we have to ask the patient to drink. Usually it is nauseous, and patients usually avoid this. So what happens is this powder, when it goes into the intestine, it exchanges calcium with the potassium there. So the calcium is getting released and potassium is binding to the resin, thereby decreasing the potassium in the body. So this leads to aggressive removal of potassium. This shall be repeated every 6 hours, which means Q 6 hourly. But very rarely, this calcium polystyrene sulfate can lead to intestinal necrosis, and it also can cause diarrhea. Other potassium binders includes patiromer and sodium zirconium cyclosilicate, which is not yet available widely in India. So we have finished the treatment for hyperkalemia. Now we will proceed with the ECG changes. There is one important rule called push-pull rule. Hyperkalemia always pulls. So it pulls the T wave, which leads to tall T wave. It pulls the PR interval, which leads to prolongation of PR interval. And it pulls the QRS complex, which leads to prolongation of QRS complex. While hypokalemia, it pushes. So while pushing, this leads to T wave inversion, and pushing the ST segment leads to T wave and ST segment depression, and there is formation of U waves. So at what levels serum potassium behaves in a way that for each level of potassium, there will be particular ECG changes. For example, for a serum potassium of more than 5.5, there will be hyperacute T waves. For a serum potassium of more than 6.5, there will be PR interval widening, as well as there will be diminution in the T wave amplitude. For a serum potassium of more than 7, there will be both bradyarrhythmia as well as tachyarrhythmia and conduction blocks. For more than 9.0, there will be development of sinus wave, which is a pre-terminal rhythm, as well as asystole and ventricular fibrillation. Hence, tachyarrhythmia can cause both, that is, hyperkalemia can cause both brady and tachyarrhythmias. So I have a mnemonic for this: tall, small, wide, and dead. Tall T wave, small P wave, wide QRS complex, as well as conduction abnormalities, sine wave, and death, which is asystole. So more than 5.5 will cause peak T waves. At more than 6.5, P wave disappears, PR interval prolongs. At more than 7, QRS widens. At more than 9, there is a pre-terminal event, sine wave appears, and also conduction abnormalities, as well as patient goes into death at these levels. So 5.5, 6.5, 7, 9. So tall, small, wide, and sinus rhythm. Sinus wave. So this is an ECG which is showing tall T waves with a narrow base, and these tall T waves are present throughout the precordial leads. So this is suggestive of potassium more than 5.5. Another ECG, it is also showing tall T waves. Along with that, there is diminution in the P wave amplitude. So this shows potassium more than 6.5. Here this is junctional rhythm. There is no P waves. So this contributes to conduction abnormalities where serum potassium will be more than 7. Here there is widened QRS complex. So this contributes to serum potassium of more than 7. Here there is formation of what is called as sinus waves. So this contributes to potassium of more than 9, and this is a pre-terminal event.